Hi, and welcome to What is This Shift? I'm your host, L. Renee. I am an LPN going into my 10th year, and I've been working in healthcare for about 40. So today's episode, the first episode, I should probably do maybe a little intro here. So what is this podcast? I want to explore how our long-term care system actually works, what the policies, the business side, the realities for staff, and what both staff and residents experience every day, but also educating the general public and especially the family members who either have loved ones in a nursing home or in a long-term care facility of some sort, and we'll discuss the differences, or who are contemplating having to put a loved one there, or those who are in facilities themselves, and basically let people know, hey, we exist, and that we're not just for old people. So I want to talk about what happens behind the scenes, what the general public doesn't know, and sometimes what we don't even know about each other. Some of these conversations may be controversial, so I want to make it clear that the opinions expressed here are of my own and do not reflect the views of any organization I've worked for in the past, the present, or the future. So that said, many of my experiences are shared by people across this field. And I've got a lot in store for you, including plenty of receipts and some upcoming powerful interviews. I believe it's time we shed a light on this branch of the healthcare tree and give it the dignity, respect, and attention that it deserves, because especially now, as the boomer generation, as it's known as, continues to age and coming into these facilities. And honestly, I'm seeing more and more of my generation, Gen X, come in, 50 and 60-year-olds, right? So, and we're going to discuss that too, believe me. So it's definitely a part of healthcare that is in crisis, as much of healthcare is, but it's mostly ignored, and it shouldn't be, because what happens with us, a lot of people end up in a long-term care facility because the hospitals are discharging them too quickly. So we're going to get into that. Most people think of nursing homes as places that were created to take care of the elderly, but the truth is that they actually evolved out of something called poorhouses, places where society sent people nobody else wanted to take care of. And that history still shapes what happens inside of long-term care today. Now, maybe some of you younger folks out there have not heard the term poorhouse, but I know growing up, my parents would say, oh, you're going to put me in the poorhouse every time I asked them for some money. Well, the poorhouses, that was a thing. They were actual places. And like I said, those were the places where society sent the people that, were basically the outcast of society. The poorhouses started roughly, the 1800s and throughout the 1930s. And yes, they were for the elderly, for the disabled, for the mentally ill, for orphaned children, and extremely poor people. Conditions were really rough. And, you could argue, well, yeah, but the life expectancy wasn't that great. I mean, they weren't there for very long. And I mean, that may or may not be true. I don't know the statistics on that. But I would imagine that they were very rough. I mean, look at how illnesses spread now throughout a facility. I can't even fathom what it must have been like to be in the poorhouse. Yes, they were more of a social welfare institution than a medical health model that we know of today, right? So in 1935, Social Security was born, and this then gave older Americans income support. So a lot of people were no longer in the poorhouse, as they did have some, livable income. So private boarding homes for the older people and the disabled and the mentally ill began to appear. And this was basically the genesis of nursing homes, but of course they were unregulated. And then after World War II, federal construction programs also helped expand hospitals and nursing facilities across the country under the Hill-Burton Act. And, please feel free to go ahead and do your own research on stuff. I'm trying not to be very NPR with my history lessons here, but basically this helped to set the tone and create the model for the healthcare system that we have today. And then what happened was in 1965, Medicare and Medicaid entered the chat. They were born. And these entities were created under the Social Security Amendments of 1965. So now at this point, Medicaid began paying for long-term care nursing, i.e., these private boarding homes. So from this point on, the government was paying facilities to house elderly people long-term and the mentally ill and the disabled. And so, of course, this incentivized people to build them because it was pretty much figured that the government was a sure thing, that you were always going to get paid, right? So in the 60s and 70s, nursing homes exploded across the country. And this, of course, caught the eye of investors because government payments being a sure bet, beds are always needed as the population aged. And so then there's always going to be customers and there's always going to be a payment base. So this started the corporate chain ownership, real estate investors, and healthcare companies. More and more became for-profit centers. In fact, 70% of all nursing homes today are for-profit. And investors saw this as sort of a huge cash cow. And then later on in the 90s and early 2000s, Wall Street began to notice the value of these properties themselves. So it's still, in these places, there were lots of allegations of abuse and neglect, as they still didn't have much regulation and oversight, even though the government was involved. So it took until 1987. From 65 to 87. I was born in 67. So let me see, in 87, I was 20. So it took 22 years. Can you believe that nursing homes have only been around for 60 years? I can't even believe it. Maybe it's because I'm as old as they are. But it took 22 years for them to say, okay, let's do something about this. And so the Nursing Home Reform Act was established in 1987. It's otherwise known as OBRA. OBRA. I forget what that stands for. But this law established resident rights, the very important resident rights that we are all supposed to know, the care standards, required assessments, and the federal inspections. That's why states coming into your place all the time. Well, hopefully not all the time. If they're there all the time, you got problems in the building. But anyway, these required assessments gave birth to the MDS, which then also became the primary payer driver. MDS stands for minimum data set, and it's a consistent, uniform way to assess the residents across the United States. I'm sure you know an MDS nurse. Maybe you are an MDS nurse. And the MDS nurse job is to make sure that these assessments are done correctly using the resident assessment instruments. And it measures everything about the resident, from the state of their body, the state of their mind, even their spirit, right? Every single thing from head to toe, in between, up and down, inside and out, is assessed. And so you want to think of it as kind of like a giant federal checklist that determines what care someone needs and then how the facility is going to get paid for that. And so obviously facilities are going to get paid based on the resident classifications that are coming from this MDS data. So more money's coming when there's more therapy, when there's more complex care, when there's more of a nursing need. And guess what getting what they need for that care would entail? Staffing. Yes, staff. They need staff. But we'll get to that. Anyway, so from these assessments, the care plan became developed, right? So one thing that people are noticing is that the people are coming in higher acuity and they're coming out of the hospitals very quickly. There is a reason for that goes all the way back to the 80s. In the 1980s, Medicare said, listen, we're not paying you guys anymore to the hospitals for every little thing that you do, because that's how hospitals were charging people per visit, right? Everything that they did, they slapped a charge on. And Medicare said, nope, what we're going to do is that we're just going to pay you per diagnosis. So somebody comes in with pneumonia, that's what you're getting paid for, is the level of care involved with treating someone with pneumonia. So I'm pretty sure this is what gave birth to all the, ICD codes and the HC, whatever the coding is done for the medical coding and billing, which I actually think I want to get into. But anyway, that's how it began. DRGs is diagnostic related groups. I think it's related. I don't know. I don't have notes. But so yeah, they paid a fixed amount per diagnosis. So the hospitals are like, well, okay, they're stable, they're out of here. But anyway, I kind of digressed, went off track on that. So let's get back to the past 25 years. Not only do corporations creating and buying up these nursing homes, but now the private equity groups, the private equity firms took notice, and large investment groups began to buy them up. And this model would separate the real estate from the actual owners of the facility. So basically, this is some big deals were done. Like in 2007, there was a whole deal, very famous, with the Carlyle Group, which helped acquire the HCR Manicare. It was a $6 billion, that's billion with a B, dollar deal. And then, a bunch of corporations would then sort of all get involved with that entity. So like imagine one nursing home building. The building itself might be owned by one company, but then another company comes in and runs the facility. And then a third comes in, provides therapy services. A fourth provides pharmacy services. So when you try to figure out who actually owns the place, it can get complicated. And especially when sometimes there's like 10 to 20 layers deep of like these seemingly shell companies. So, is this structure intentionally designed to limit liability if something goes wrong with the facility? I mean, some people think so. Not to mention it can be cost effective for the investors. And then if you have just the operating company, which would be the nursing home itself, on paper, that facility can look broke. Because that operating company, they're paying everybody else. They're paying the rent to the one company. They're paying the fees, the service fees. They're paying, they're paying service-related companies, paying management fees. So they can look broke. But the thing is, in reality, the investors are still turning a profit and earning on the rent, service contracts and fees, etc. So the nursing home can then say, well, we're broke. We can't get more staff. We can't get new equipment. We can't do this. We can't do that. But the company itself, the investors, they ain't broke. And they ain't never going to let themselves be broke. Okay? Just my opinion. And I've personally seen where there is a nursing home company. Now, I don't know if it's the real estate company, the investor group. I don't know where on the, the pyramid. I mean, I don't know where they sit on the ladder, but this company is buying up x-ray companies, physical therapy companies. So in-house, basically, like labs. So when you are working and you need a PT or you need an x-ray, you're going to call that company that's owned, but I don't even know how that's legal. I honestly don't even know if it is. Like, that sounds very monopoly-ish to me, or conflict of interest at the very least. I'm not sure, but it is happening. And I'm not going to name the company because, I can't do that. I should probably look more into that, though, before I just start talking. But anyway, yeah. The labor itself, okay, the labor cost, what pays our paycheck, is literally eats 60 to 70% of the nursing home operation costs. So all the other companies and all the other owners and the investors, they obviously want to keep those costs down. So, and here's a fun fact. Some hospital systems, not as much as these private companies, but some hospital systems were also buying up nursing homes and therapies and things of that nature, because once Medicare instituted a penalty for readmissions, hospitals get penalized. If they discharge a patient and that patient comes right back, hospital gets in trouble. So they're discouraged from discharging too soon, but their solution to that was, let's just put them into one of our nursing homes. And then that way, if they could control readmission theoretically, then they could basically, follow their whole care. They could control every stage of the person's care, and then that way they could maximize profit and then keep the penalties down. But because of these hospital penalties, the SNFs, the skilled nursing homes, started to see higher acuity patients coming in. Now, I'm going to throw this fun fact in too. Research from Harvard Medical School and the University of Chicago found that private equity-owned nursing homes were associated with higher patient mortality rates, lower staffing levels, and higher ER visits. And ironically, that's the thing that hospital-bought facilities were trying to avoid. But have you ever noticed that nursing homes are very reluctant to send people out? They don't want to send a resident to the emergency room if they can help it. Have you noticed that? If you have, I'd be interested in knowing if that's just a anecdotal observation of my own, or if that is something that is actually a thing. Because I'm assuming that Medicare would have the same sort of penalties for, I'm not exactly sure, but I think it has something to do with payment. But I don't know for sure. That's why I have to get some experts on here, and we're going to interview them, because we're going to get these things that I'm unsure about answered, because I do believe it's very important for us to know our past to understand our present, right? We have to understand how we got here, because it ain't working. But we have to understand that it failed at some point. Like what was the fail point? And I personally believe that the introduction of non-medical people, non-clinical people who are not investing in the actual patients, but rather in the profit from people being ill or in need, was the problem. The marriage of corporate and healthcare, which to me is a toxic marriage, and they've never should have gotten together. They make terrible bedfellows, and we already know which is the abused spouse in that equation, right? And when people talk about nursing homes today, they're really talking about a system that evolved over 2 centuries, from the poorhouses to government-funded care to corporate health care to this private equity investment that we're seeing today. And it's really important to understand how that has affected what we deal with. And I'm probably preaching to the choir. We all kind of know this. Healthcare for profit is the problem. But that's not really the elephant in the room, and we're going to get to that. So I want to thank you for joining me, and I hope that you'll still continue to tune in, because episode 2, we're gonna talk a little bit more of outlining and discussing what the long-term facilities are. What is the difference between a nursing home and a SNF? And what does SNF stand for? What is an ALF, an assisted living facility, versus a nursing home? What is subacute? What is long-term care acute, an LTAC? Like all the different entities that fall under the long-term care umbrella, so to speak. But also, how did LPNs happen? Like, where did LPNs come from? And did you know that LPNs were created because there weren't enough nurses? There weren't enough RNs, registered nurses? And what are the differences between the two? And then we're also going to discuss a little bit some of the beefs between the two of them and the misconceptions of everybody. Not just the general public, but just to everybody. So please stay tuned. I hope you will. And please, let your friends and family know, your fellow healthcare workers know. And I really appreciate the support and the encouragement. And I really hope to bring you less dry and statistical and more real, like what's really happening behind that call light. So thank you for tuning in again.